Thank you for joining us. My name is Theron Steinke, and I am honored to introduce you to our team of clinical educators and local prosthetists and orthotists. It is our firm belief that patients living with limb loss receive the best outcome possible when we take the team approach to their care. The relationship between the prosthetist, therapist, physician, and other treating medical professionals starts and ends with open communication and education. We learn just as much from you as we hope that you learn from us, and it is our goal to make these presentations a conversation, not a lecture. We sincerely thank you for your support and devotion to this specialized patient population.
Hi, my name is Renee Van Velde, and I'm a physical therapist. I work for an orthotics and prosthetics company in the Midwest. I do a lot of education presentations to both practicing therapists and students, as well as consulting with our practitioners for patients with lower extremity amputations. I worked for over 20 years as a physical therapist at a level 1 trauma hospital locally, mostly in the outpatient department, treating patients with amputations as frequently as possible. I also taught in a local DPT university program for 14 years, teaching content on wound care and amputations, as well as serving as the director of clinical education. Now, my passion is continuing with education. I like to help as many people with amputations as possible by training therapists. I enjoy training therapists who have been therapists for a long time, who treat amputees routinely, as well as helping people who don't treat amputees very often to feel comfortable with this content. I want them to feel like they have the words to ask the right questions of their local practitioners for best patient outcome. Hi everyone, this presentation is focusing on the acute care phase for patients with lower extremity limb loss. So we will be focusing on lower extremity during this presentation, although some of the principles we'll talk about can also apply to your upper extremity patients with limb loss in the acute care setting. So you'll see by this course description, which you should have received in your handout also, we're going to talk about compression first and foremost, which is number one, I think, in importance. We'll talk about phantom limb pain, how you can address that in the acute care setting. We'll talk a little bit about positioning, which is something you know a lot about already. And then we really want to talk about some discharge planning options for you for consideration, as we know that's a very hot topic in acute care. Here are your course description, or your learning objectives for this course, and they match what the course description says. So, starting out, we're going to talk specifically about compression, and I really want to highlight these points. So we'll take a quick look at what's on the slide and then talk about it for a minute. So, some type of compression is necessary and extremely warranted in acute care. The question is what type, right? So that's what we're going to be talking about. Good compression doesn't just help with edema control, it helps with pain control and limb shaping. Those are important points to share with the physician. The best scenario, if we can do it, is medical level compression. And that's 20 millimeters of mercury to 30, if possible, in the acute care setting. I'll talk a minute about how to make that work or when it isn't appropriate. Compression is not contraindicated because of sutures or staples. There might be other contraindications, but don't let that be the thing that makes you not think about applying some kind of compression. And then we might, as therapists, we might be the ones who are asking for post-surgical compression on a little bit more focused level than what anybody else might be thinking about in acute care. So the big picture here that I want to share with you is the importance in us as therapists taking the lead in this conversation with surgeons. So surgeons were in there, right? They understand the limitations of the patient, the comorbidities, all of those indications for or against compression. It's also in our scope of practice as therapists. I can guarantee you that in the first year of PT school, that's what one of the many things that our students are learning is appropriate compression, yellow flags, red flags, etc. We know those things. We can look at someone and say, you can handle it, you can't handle it, based on all of the information that's presented to us about the patient and from the patient. The thing I think that is important to think about is patient selection, of course. So I tend to break these amputee patients in general into two categories. There are the vascular patients and there are the orthopedic patients. And honestly, the patient who lost their leg either below the knee or above the knee for related to a diabetic foot ulcer that was long standing, I consider those people orthopedic in nature unless they also have a large vessel disease of some kind of notable occlusion that would make compression something that you want to wait on until later in the rehab process. So otherwise, I think it's really important to be going ahead and moving forward just as we would with a patient who had they broke their ankle, let's say, or they had a knee surgery, and we're going to compress those people orthopedically. I think the same thing can be true for the lower extremity amputee. If they have good bony structure remaining, good soft tissue remaining, they're healing appropriately, even if they have sutures or staples in place. So those are the big concepts. Again, we might be the people who are starting that conversation with the surgeon. So in my acute care experience, we've often put shrinkers on patients while they were still in the acute care hospital, especially the transfemoral level patient. And I'll tell you why that's important in a moment. Again, not appropriate for everyone. That's really what we want to make sure that we're talking about, is delineating those patients. So we'll talk a little bit about our soft dressing options. These are the things that we see the most. ACE wrap. That's kind of where it all starts. So how many of you have been in the situation where you've gone into the patient room in acute care, they have a big bulky dressing on, it's usually a pile of Kerlix, right? And there's this loosely wrapped ACE wrap over it, then that's how they came out of the OR. The ACE wrap might not really be providing any compression, it's just holding on the Kerlix. You get them to transfer, they stand up, the whole dressing falls on the floor. I think that's more likely for our transfem patients because there's really nothing holding that thing up. They lose a little girth post-op and it falls off. So that's one of the cons of ACE wrap, is applying it appropriately, knowing that it's a high stretch bandage, right? You need to reapply it routinely to make sure that you're getting uniform compression for the limb. And then once it stretches out, you reapply again. Also, patients have a very hard time learning how to do this themselves. Even the transtibial patients, they think of the sitting balance they need to be able to lean over or put their leg on the bed sideways and wrap their leg appropriately. So in my 20 plus years career of working with patients with amputations, I think I've had 2 people who could wrap their own residual limb properly with ACE wrap. And those both were trans-tib patients. And that's, it doesn't mean they can't do it, and you can go ahead and train them to do it if that's the right thing. But it's also not the best. Now, on the flip side, it's cheap. Why does it get used? It gets soiled, you toss it, you get a new one. They just don't last very long, but they're also pretty cheap to replace. So that's really what we see as the primary choice of compression in the acute care setting, because that's what people are coming out of the OR with. I know you're familiar with that. So finding a way to adjust that, if you don't have any other options, then try to work on proper application of the ACE wrap, teaching the patient how to do it, teaching nursing how to do it properly. If you're doing a dressing change or dressing inspection, trying to minimize the bulk of the dressing so that you get better uniform compression. That's our best case scenario for those patients. I'll say there are a few videos you can find on YouTube for limb wrapping, and they're decent. They're not wrong. You can also find a lot of handouts out there to give to your patients to be working on at home once they get discharged, if they're going home with ACE wrap. The funny thing is, I don't know that there's a really right way to anchor either one. So you'll see figure 8s as that's the baseline. That's what we want for both trans-tib and trans-fem. Multiple layers. We want to capture those corners of the limb so that we're avoiding a misshapen limb or dog ears. And then we want to anchor this. So my typical approach was always to anchor for the trans-tib, to anchor proximal to the femoral condyles, using the femoral condyles as a handle. I've seen other people wrap just to the tibial tubercle. You've got to make sure that you capture all of the bulk of the gastroc all the way up to the popliteal space. That's why I kind of like going above the knee. You can leave the patella open. I've seen it done both ways. For the transfem, you have to have a hip spica. This thing is not staying in place without a hip spica and more than one layer of really firm wrapping in a figure eight pattern all the way up to the pubic ramus. So the trick is you can do the hip spica before you wrap the limb as the anchor, or you can do it at the end. It doesn't seem to matter. I've seen videos with both methods. All of the other pieces and parts of the dressing are the most important, making sure that you're having uniform compression. Think about how hard it is for the patient to roll around in bed in acute care and lift themselves up so that you can get that ACE wrap under them. Also a trick for us in acute care. Another positive in that is what a great exercise for the patient in bed mobility. So you make that decision if that's something that you feel comfortable doing. But those transfem patients are the ones I find that take longer to prosthetic fitting because it takes longer for them to get appropriate compression, and there's so much more soft tissue. So that's the struggle that we run into with those folks on the prosthetic fitting side. So that's something to keep in mind when you're thinking of asking the physician for some kind of more appropriate compression. So that's ACE wrap. Now let's talk about shrinkers. Again, you might not encounter these too much in acute care, but I want to encourage you to start pushing this conversation a little bit more with the physicians. So you'll see on the top of your screen a trans-tib version, on the bottom of your screen a trans-fem version. What we like about a shrinker is it's a whole lot easier to don than ACE wrap. It's simple. It's typically one step, maybe two steps. It's easier for the patient to do it at home. They can keep it in place longer in the right position, and it's easy to launder and take care of, and they don't wear out in the same way that ACE wraps wear out. On the negative side, they require an order. It's medical equipment. They need to be fit by a licensed or certified prosthetist, and that's also can be a challenge. So in acute care, you might need to, if you're going to move forward with this, you might need to move forward with getting a PO for this if the patient's going to be in the hospital for a few days. Or if they're about to discharge, you might be able to make that work on the day of discharge with the prosthetist and bill to their insurance. Call your local prosthetist. They're the ones who can answer those questions about billing and what the orders need to say about your particular patient. So let's make sure that we're taking advantage of their knowledge on a case-by-case basis. So related to shrinkers, I wanted to make sure that you knew what the different types were. So this is the one that's in the top picture. This is kind of traditional. It's really tubigrip material, so it's sized by girth. A little bit by length, right? But most of these are used for the trans-tib patient with a variable residual limb length. So they allow for some variety in the limb length. This is really not going to work for a transfem patient. It is just going to roll down. It's not going to stay up. It almost doesn't matter the size of someone's thigh. So the way that these work is going onto the residual limb, and you'll see in the picture it goes above the knee several inches. You want the second layer to be shorter than the first. Then you have this ring. You slide the ring up to the bottom of the residual limb, and then you double it back over itself, and so you have two layers of gradient compression. This second layer can go above the knee as well. If somebody has a lot of swelling, you might want that. The bummer about that is then you get a lot of fabric in the popliteal space, and that can bother people, or this layer can bunch up or roll down. So you could just take the second layer to the tibial tubercle and get your focused compression below the knee, knowing that you're moving the fluid up anyway. So that's the traditional approach. with the end, you want to avoid a big hole. You don't want a lot of flesh that you can see because that's a place where the patient's not getting compression. Now, you can, if somebody's ready for some level of compression and the physician says they're not ready for this yet, this level of compression yet, or they're not readily available, and in your clinical judgment you feel that applying some compression better than an ACE wrap is appropriate, you can do this yourself with Tubigrip. So I've done this plenty of times in the clinic where I just chose a larger size of Tubigrip, something that's not going to give them 20 to 30 millimeters of mercury. Maybe it's going to be 15, more like an ACE wrap, for example. And that's really going to hold the dressing in place. And you can do the same thing. You just won't have the ring. You turn it 180 degrees and double it over itself. And then you have a little knot on the end. You just want to make sure you don't have any pressure on the incision line with the knot. So that is something that I've done. I've usually waited until I've talked to the physician or the physician extenders in that situation. So that's trans-tib traditional. This is what our company is going to. Double check with your local company about what they're using. I really like this a lot. I've done a lot of edema care in the past, a lot of wound care, venous insufficiency, ulcers, and this is that same compression material. One layer makes it a whole lot easier than the other one, and it might be better for somebody with hand dexterity issues. The top of it has silicone beads, and that's how it stays up, rather than having to come quite so far up on the thigh, although you do want this to come over the knee. The seam is flat. You're not going to have any pressure on the incision line. Much better, in my opinion, for compression. Not everybody uses them, though, and that's okay. So that's something that you might want to ask your prosthetist for. For a particular patient, right? Maybe it's warranted for a particular patient. For TransFem, this is the traditional shrinker for the TransFem patient. So it's got a soft brim up here that goes up to the pubic ramus. So that's kind of comfortable for people. It does need a specific length measurement because we don't want a bunch of material bunched up here. We want this flushed to the distal end of the limb, or you're going to have swelling that just kind of pools there. Then it has a hip spica, which nobody likes. So that's the bummer with this traditional style of TransFem shrinker. However, is this better than ACE wrap? Yes. Is this better than nothing? Yes. That's why I push TransFem more for the right patient in acute care. This also can be TransFem. That's one of my favorite things about this. So you've got this grippy silicone. It's going to stay in place. This is also going to capture that adductor material better so that we really compress the proximal thigh and get a much better limb shape. That's another thing to consider. If someone has tried this and it won't really stay up in place if their thigh is shaped differently, one trick is to use body glue. There are some different ones on the market. The one we used to use for compression garments is called It Stays. That's a brand name, and I believe it's still on the market. It's almost like a roll-on, makes the skin a little tacky, like a barrier. That's another trick for keeping shrinkers in place. So that's the general scoop when it relates to shrinkers. At the bottom of the slide, you'll see I have a bullet point about patients have a choice. And that's something that we try to push with our therapists that we're talking to all over our organization as well. This is a sensitive subject, and it can be in acute care. So if your hospital has a contract with a particular orthotic and prosthetic provider, that company might have first dibs to come in and provide something for the patient, but the patient can still pick who they want. So that's important. So giving the patient a choice. In the hospital where I worked for many years, a county hospital, level 1 trauma, we provided a list of all the providers in the area to help the patient make a choice. The other thing to know is if somebody gets a shrinker from one provider, a prosthetic provider, and that all goes fine, that transaction, which does go either to the DRG or to the patient's insurance, that transaction does not limit the patient for where they're going to get their prosthesis later on. So if they want to interview other companies, other prosthetists later, when they're really more ready to talk about the process of getting a leg, then they're welcome to do that. So we want to make sure that patients have a choice. That's part of the consent process with HIPAA too. Okay. So there are also rigid removable dressings. I want you to be aware of this specifically in acute care. This is the one that our company uses. The brand name is called Rooke, R-O-O-K-E. I know there are other ones on the market. Check with your local provider about which one they prefer. We call this the Ugg boot because it's all fluffy. This is specifically for trans tib. It is washable. It can get kind of gunky over time, right? Gunky is a medical term, right? So that's what this thing looks like. The bottom of it is 2 inches thick foam. So you can also adjust. The prosthetist would be the one who would come and fit this to the patient. And there is a specific order required for it. BK stump protector or trans tib stump protector is the terminology. The concept is if the patient falls, they fall on this, not on the end of their residual limb. That, hands down, it's phenomenal in that regard. Therefore, this is really appropriate for your patients who are at greater risk of a fall. Not necessarily for your higher level K3 patients who are pretty mobile, getting around, and they just need, just a regular dressing and maybe some compression. This is for the people who are either lower level at more risk for falls, or they're not making great choices either. So I've had a few people who had the potential for being higher level patients with a prosthesis, but they were crawling around on the floor at home, dragging their limb behind them, putting pressure on their incision line, falling, you name it. Remember that the diabetic patient, if they've gotten to the point of losing protective sensation so that they require an amputation, their other foot is toast, right? They do not have any protective sensation on that side, and they're going to lose ankle control. Their balance is already limited and challenged. That might also warrant that this would be the right thing for somebody who might lose their balance, even with an assistive device. For the trans tib patient, if they start to fall, they typically reach out with their residual limb and they land on that because they think their foot is still there. It's a habit, right? And they're going to be more likely to require a revision surgery, unfortunately. Trans femme patients don't do that. They just fall on wherever. We don't want them to fall on their hips, obviously. Another benefit of this is it has a rigid posterior stay. It promotes knee extension. And it also comes with a hip strap so that they can stand up and transfer and they don't have to worry about it falling off. So that is an option. That might be something that you think is the right thing for your person, not appropriate for everybody, but I wanted you to know that that exists. The next option is a true rigid removable dressing. I'll skip over this, won't spend too much time. This is what it looks like. It's a cast. These are made for the patients, and they're suspended with a strap that is a supracondylar strap. The hospital where I worked, we made these ourselves in therapy. The prosthetist can also make this if this is a better choice for your patient than the Rooke or another stump protector. What I like about this is they fall on it, this breaks, their leg doesn't break. The prosthetist can make this, but it does require a specific order for that. Again, that might be the right thing that's appropriate for your patient. Make sure that you're having that conversation with your prosthetist. So those are the dressing options. I want you more than anything else to be aware that there are options, to be having those conversations with other therapists, with the physician extenders, to make sure that somebody is getting the right thing. I realized I just forgot one point. When you're adding a soft shrinker on and somebody still has sutures or staples, a trick is to really open it up like this and place it over the end of the residual limb, and that way you're not tugging on the incision line. So let's not dehiss. That would be the wrong thing after we're trying so hard to help people heal. So any questions you have, you can certainly go ahead and have that conversation with the practitioner. All right, let's move on. You can tell I'm passionate about compression. I want to make sure you know about all of the options available to you and how important it is. So let's talk briefly about phantom limb pain. Very important to address with these patients. Let's not presume they have it or presume they don't have it. I really like to make sure that I'm talking to patients openly about it, giving them the opportunity to describe their pain. Most people are going to have some level of pain, and on this slide there's some descriptors. By the time they get to outpatient, it's often more of a nighttime thing, although it can bother them certainly during the day. It's often also related to pre-operative pain. Makes sense. So that knowing the patient's history when you go into their room to see them might help you place more emphasis on this. So here are a couple tips for you. Distinguish between sensation and pain. Can you feel your foot, or does it really hurt? There's a difference there. And then make sure that you're also distinguishing in your note your pain rating for the patient. So you're going to have them rate their pain anyway on their residual limb, their incision line, all of those surgery-related pain. But I would, in a separate place in your note, also note the phantom limb pain that they're having, making sure that you're distinguishing that. That starts to give them the language also to be able to talk to the physician about it or to anybody else about it. And then you're also communicating with the physician. I've rarely seen a physician ask these kind of questions, especially in acute care. That's why I think it's so much more important for us to make sure that we're doing it. The physical medicine and rehab docs, they get it more than anybody else, but they're rarely consulting in acute care, maybe post-acute care in an inpatient rehab setting or in outpatient. But in acute care, it might be us on the therapy side. So here are a few interventions for you to consider. These are in no particular order. I would suggest that you create a handout for your own hospital setting, your own team, for patients to address phantom limb pain and sensation. So number one is compression. That's the thing that's going to give us the really great results in addition to managing the other things I talked about. Again, these are things that I don't know that all surgeons really know. So communicating with the surgeons, having an open conversation is always a great idea. Isometric, isotonic exercises. So specifically for the trans-tib amputee, those are ankle pumps. They're going to think you're a little crazy, but they really work. They can really help. Not only do they start to clue patients in, oh, I can still move these muscles, even though they're not attached to an ankle anymore, I can still use them. We're also sending messages to the brain to create a new normal. I do this sitting on the side of the bed where possible. If they're a unilateral amputee, I like them having their intact foot on the floor, and then they can be doing these ankle pumps. They're getting some sensation. They're doing them on their intact side. They're doing them on their amputated side. If they wake up in the middle of the night and they have a sharp pain, they can pound out 20 reps. I think plantar flexion is the easiest. Everybody knows to press the gas pedal. It's dorsiflexion that's a little trickier to make sure somebody knows how to do. Even, I've had that problem with patients who aren't amputees who broke their ankle. So I'll use fingers, place somebody's fingers on the muscle belly of the anterior tib, use their other leg as a demo, etc. I also then, for the transfem patient, will do long arc quads and hamstring sets, right? So for the hamstring set, they could do that in sitting too, just pushing down into the bed or into the chair and then doing their long arc quads. And here's the kicker. For the transfem patients, I also like to have them do ankle pumps. So this is a mental exercise, as you can imagine. We're remapping the neural centers in their brain and trying to help their brain understand what has happened. So they really think you're crazy. But giving them those exercises in acute care with a handout, you can do that. Hey, patient, you can do this whenever you want. If they're having an episode of pain, do it while you're having the episode of pain. If they're not having an episode of pain, then maybe every couple hours they set an alarm on their phone, they pound out 20 reps of each type of exercise. Then desensitization. This is classic stuff, right? And also think about donning any kind of compression. If it's ACE wrap, If it's donning or changing a dressing or putting on a shrinker, that's desensitization. That also fits in the same category. Light touch massage, the more someone's acknowledging their residual limb and touching it, rubbing it, the better it's going to be. I've had patients tell me, who are trans-tib level patients, they can find a spot on their thigh when they rub that it addresses their phantom limb sensation distal to their amputation. Pretty interesting. So they're finding those neural pathways. So encourage people to experiment with that. Then there's also mirror therapy. Let's not forget, that's a classic. I don't see you doing that much in acute care, but again, you might be able to develop a handout for someone to try once they get home, if they're going home. If they're going to an inpatient rehab setting, still send the handout. The inpatient rehab folks can also be working on that with the patient. Same thing with a sniff, same thing with home health. Making sure that the patient knows at least to ask about it. Hey, I heard about mirror therapy in acute care. Can you help me figure out how to do that? There's phenomenal research now on it. OTs have done a lot of that on hand patients. It's a little harder for us with legs because with a hand patient, there's just a mirror box and they stick their hand in, it's on the top of a table. For the lower extremity patients, it might be an apartment mirror, and you see this picture of the patient in long sitting, looking into the mirror on the intact side. You can match mirror therapy with the isotonic exercises as well. Let's not forget about ice. Ice, right? It really can make a difference for patients. Our patient liaison is a transtibial level amputee, and his father-in-law had a cryo cuff. And when he had his accident and he came home from the hospital after his amputation, he took this cryo cuff and kind of finagled it to fit on the end of his residual limb, ran that thing throughout the day. He said it made a huge difference in his pain management. It didn't take the pain away, but it took the edge off enough that he could tolerate it. He had less anxiety about his pain. So letting people know that that's obviously a thing that they can use. That's our bread and butter as therapists, right? Kinesiotaping, we might not do this much in acute care, but there are some techniques that would not cross the incision line that might also address some of the edema. And then having people do mindfulness exercises, thinking about their pain, imagining their pain going away. That seems kind of crazy sometimes to us, especially in acute care, but really allowing somebody to get in touch with what's going on with their pain. I've had a lot of therapists approach me after teaching that I've done saying, hey, I've tried this and it's really worked with patients. So I hate to imagine, I hate to discount that and not bring it to your attention. So those are the interventions for phantom limb pain. Again, laundry list. Feel free to do with that whatever you want as far as creating a handout. Okay, next topic is positioning. This is not a surprise for you in acute care. We know these things. These aren't that hard for us. I want to make sure that I'm not glossing over it though. So for trans-tib patients, knee extension, we know knee extension. That makes sense. Those of you working in a hospital where you're treating patients after a total knee replacement, you know this. Nursing is probably more cued into it in total joint floors about not putting anything under the knee and really educating our patients that the ultimate goal is walking with a prosthesis, right? If you allow your knee to get stuck and flexed or get tight, you're going to have more difficulty walking with a prosthesis. The end game is pretty clear for them. Here's the other thing I want to point out though is hip extension. I've had many patients over the years come to me after an extended postoperative healing time and they have hip flexion contractures. Trans-tib patients, at least a unilateral hip flexion contracture, maybe bilat if they've been spending a lot of time in a wheelchair. Maybe somebody thought to get them a knee extension board for the wheelchair, but they forgot to talk to them about either side lying with hip extension. Prone is where it's at, if at all possible. We know in acute care that's harder, but I think it's fine to give patients a handout that talks about in a week or two, Now start working on prone and laying on your tummy a few minutes at a time. I don't expect you to sleep that way. I want you to at least spend a little bit of time on your belly every day. This is where in outpatient, I would have patients come in and start right away on a prone press up progression. So you might also give them that as an aspirational goal, home exercise program if you can't get them into prone while they're in the hospital. All of this is working toward eventual successful fitting and ambulation with a prosthesis. Okay, and then I think on the picture there's a knee extension board for that particular wheelchair, which I think is really helpful. So for the trans femme patient, there are also really important points to make. Hip extension, that's a no-brainer for these folks, right? We know that. And I'll tell you, being the one who ends up with the patient with a transfemoral prosthesis, the more hip extension they have, the more they're able to generate hip extension power, equals them being able to walk better with a prosthesis and control the prosthetic knee. No question. So that's incredibly important. I think that's not a surprise. I think what's important too is to think about our patients in acute care. They're sitting propped up in bed, and we know that's already hip flexion. So then some well-meaning person comes along and puts a towel roll under the end of their residual limb, and now it's pointing up as if that's going to help with edema. It's not. That's really not elevation. So now you have hip flexion from the bottom up, hip flexion from the top down. That's a mess. So getting people to flatten out as much as they can, learn to stretch out to the best of their ability, that's really what we're looking for. Also, if they're in supine, we want to avoid abduction. We want to trend towards adduction if possible, and then avoid external rotation if possible. So that's the typical relaxation position. So maybe a bolster, some kind of towel roll on the outside, teaching them to do that when they go home. So discharge planning, I promised we'd mention this a little bit. We really want to make sure that people are following up with therapies post-discharge. And I know that's not a big surprise to you. So it depends on where they're going, of course. For the patients going to inpatient rehab, you're golden. For the patients going to a skilled nursing facility, you're golden. For the patients going home, this is where they can fall through the cracks. Making sure that they either have home health or outpatient. Some of you might think, and honestly surgeons might think, they don't need to go to outpatient until they're ready for a prosthesis. I disagree. I couldn't disagree more. There are so many things in outpatient that we can be following up on to continue getting them ready for a prosthesis. Don't worry about how much insurance they have for visits. Let the outpatient people worry about that. That's what we do. So if somebody comes to me and they only have 12 visits total, maybe I use one pre-prosthetic, maybe I use two, but I want to make sure that they're moving along, they're healing properly, and I can get them ready for a prosthesis and take into consideration what they're able to do. And that's something to encourage the patient in. Hey patient, you need to be the squeaky wheel, making sure that you're following up with therapy to the best of your ability. And then I also mentioned here about an amputee clinic. I was fortunate to work for many years at a hospital with a consistent amputee clinic run by a PM&R physician, and I staff that clinic frequently. All of the patients in our hospital, when they leave our hospital, are automatically scheduled for an appointment in amputee clinic, even if they go to a SNF. So they're leaving the SNF and coming to the amputee clinic just to make sure that they're progressing appropriately. That was just our habit, and it really helped prevent people from falling through the cracks. If you don't have an amputee clinic, obviously a post-op surgical visit, we want to make sure that they've got those, and maybe following up with their PCP, or if there is a rehab physician in the area who is interested in working with these patients in outpatient, that would be a great referral as well. Lastly, I think we'd be remiss if we didn't talk about prosthetic prescription. And a lot of you in acute care are saying, wait, this is not the right time for that. This is too early to talk about prosthetic prescription. I guarantee it's not. Your patients are thinking about it. They wake up from surgery. They want to know if they're ever going to walk again. And I've talked to so many patients, very active people, who said they thought they were never going to be able to do something again. In fact, yesterday I encountered a patient with a transfemoral level amputation. He's got a prosthesis. He's been active for a while. He's a kickboxer, fights jujitsu. And he showed me some video of him standing on his prosthetic leg, kicking with his other leg. Amazing. But he already was a fighter when he had his surgery, and he was really afraid he'd never be able to do it again. So our patients are thinking about it. You don't have to be an expert in this particular area. This is why I think it's so important for the patient to start to get consultations while they're in the acute care setting. And it shouldn't be a sell job, right? This should be a patient advocate. In our market and with our company, I can be the one who comes and does a post-op visit with the patient, our patient liaison, or a prosthetist. Talk to your local prosthetist about how they manage these kinds of consultations. The whole point at this stage is answering the patient's questions. It's not selling them anything. It shouldn't be selling them anything. Providing them information when they're ready to think more about it, giving them contact information, but just answering their questions. What does the process look like, etc.? What will I be able to do moving forward? And how do I start this process? I can guarantee you that 3 weeks later or 2 weeks later, the patients will have the same questions all over again. That's okay. Now they have some people to call. I like for them to talk to representatives from more than one company, but that's my preference. You can manage it however works for you. Again, great conversation to have with your local prosthetic team to find out their preferences. We know also that COVID has limited some of these visits. We're back in hospitals in our market. I know that's not the case everywhere. We can also do virtual visits with a HIPAA secure Zoom account. So again, talking to your local folks about how to do it. Here's the best part. Consultations are free. There is no physician's order required. The patient drives this process. Yes, I'd like to speak with somebody. No order, no charge. They can do whatever they want in this particular situation. So that, I think, really makes it a positive for everybody. And it also means that you as the therapist don't have all the answers. Don't have to have all the answers. You can sit and listen, but you could also do your documentation, move on while the prosthetist is answering the patient questions. So then that follows to this next bullet. The patient should be encouraged to begin that consultation even before they're ready for prosthetic fitting. The patient needs to be informed that they have a choice in where they can go. And once the incision line is healed, that's when prosthetic measuring and fitting can begin. They might ask that question, and that's another reason in your in your home exercise program and patient education to talk to them about the need to follow up with all of these interventions you've given them to heal. They can't start on getting a prosthetic leg until they're healed. So hopefully that gives you some ideas to really ramp things up in your particular setting, and also to create relationships and conversations with your local prosthetic team. At this point, I'll turn you back over to them for some specific questions and answers about how they manage these things in your market and how they can serve your patients and help serve you as well. Thank you so much for attending. I hope this has been helpful for you. Take care.